Hello, and welcome to the first installment of the Health Storytelling Author Q&A series for this fall semester and academic year 2025-2026. I'm Maryn McKenna. I'm a journalist and author and senior fellow in the Center for the Study of Human Health at Emory University. And I'm the curator of this series, which makes me your host as we undertake our latest set of author conversations. In a moment, I'll introduce you to my guest, Jennie Erin Smith, a journalist and author of the powerful and moving new book, Valley of Forgetting: Alzheimer's Families and the Search for a Cure. But first, let me tell you about this series. At least once per month during the academic year, we invite writers whose journalistic or academic books examine health, the science and history of health, and health's intersection with society. This series of conversations is sponsored by the Emory Center for the Study of Human Health, along with an array of fantastic co-sponsors whom we're so grateful for. This autumn, those are the Georgia Center for the Book, a local affiliate of the Library of Congress, which stages very frequent public conversations with authors, illustrators, poets, and others to bring news of new books to the public. And Emory's Center for Public Scholarship and Engagement, which creates opportunities for faculty, staff, and students to share ideas with local and global audiences. And the center's new Ideas Festival Emory, which launched a year ago on Emory's Oxford campus and returns next month with an amazing lineup of speakers. Let me tell you who'll be appearing in the next few months in this series, which is live streamed on YouTube, LinkedIn, Facebook, and Instagram, and archived on YouTube, where you can find 5 years of interviews like this. The authors appearing this semester are, tonight, Jennie Erin Smith with Valley of Forgetting, which was published in April by Riverhead. On the 22nd of October, Star Vartan with The Stronger Sex: What Science Tells Us About the Power of the Female Body, which was published in July by Seal Press at Hachette Books. And on the 19th of November, Aram Alam with The Care of Foreigners: How Immigrant Physicians Changed U.S. Healthcare, which will be published in October, it's not out yet, by Johns Hopkins University Press. Here's one final note. This is a live event. You can interact with us, and we encourage you to do that. If you want to ask a question, please comment on or reply on any of the platforms where you're watching us, and our producer, who is Stefan Kaplan of Spin It Social, will make sure we see what you've said. Do note, I'll turn to your questions in the second half of this hour, but you can put your comments in at any time, and I promise we'll get to them. Now let's turn to our book and guest. Jennie Erin Smith is a journalist who has written for the New York Times, the Wall Street Journal, the Times Literary Supplement, and a number of medically focused publications. She's also the author of Stolen World, a tale of reptiles, smugglers, and skullduggery. Almost 10 years ago, she watched a news report on unique occurrences of dementia in families in an area of the country of Colombia. She upended her life to pursue that story, moving to Colombia to live alongside the families in deeply impoverished areas in order to understand their suffering. And that experience became tonight's book. Jennie, welcome to this series.
Hey, Maryn, thank you.
So this is also always the first question I ask people. And given the story I just briefly referred to, it's even more important in this conversation. Who are you, and how did you come to write this book?
I'm your basic science reporter. I started my career in a newspaper in Daytona Beach, Florida, as an environmental reporter. And over the years, I built sort of a freelance career as a reviewer of science books and a freelance reporter in different different areas. In 2011, 2012, after I had published my first book, which was about reptile smugglers in Florida and their relationships to zoos and museums, I kind of took off with my husband for Latin America, and we spent a few years there. And so we learned Spanish. And so I sort of broadened into a science reporter about Latin America during that time. Then around 2015, we moved back to the United States, and I was hanging around Florida again in 2016 when I saw an episode of 60 Minutes. I was watching TV with a friend, saw an episode of 60 Minutes about what eventually became this story, which was a group of people in Medellin, Colombia, who were all related, thousands of people, who shared a genetic mutation that produced Alzheimer's disease in their mid-40s, and a heroic, handsome, pioneering doctor who was taking care of them.
And so most of us, if we saw something like that, would think that is a really interesting story. Maybe I'm going to go see if they put something on the website, and then we'd move on.
Mm-hmm.
Your response seems to have been a little different.
Well, that had to do with a few factors. First, where I was in my life. I was bored. I was 5 years out from my last book. I was in sort of dire need of a new project. And I had, as I just said, I had lived in Latin America for a couple of years, and I had some familiarity with Colombia. I'd already been there a year, in Medellin specifically. And there were a few things about the way that story was presented that struck me as strange. And just for context, the story of the Colombian Alzheimer's families and of Dr. Lopera, the lead investigator of studies in them for 40 years. He passed away last year, but this story's been told many, many times. The New York Times told it in 2010, 60 Minutes, and like all kinds of documentarians have told this story. But the aspect of it that I felt was odd was that this was a clinical trial happening in a group of people who might or might not have a mutation that gave them Alzheimer's in their 40s, because not everyone in these families had the mutation. 50% of people inherit the mutation from a parent who has it. And so when they spoke to the press, when they spoke to the TV show, they were expressing the sentiment that they didn't want to know whether they had this mutation. They preferred to trust in God, or, they would say these sort of pious things. Knowing Colombia the way I did by that point, something struck me as convenient in that presentation, because I knew that Colombia, for all it had been through, and we could talk about that, was also a very fast-moving society with lots of interesting young people who, wanted careers and wanted lives. And so it struck me as unlikely that they wouldn't want to know if they were carriers of a mutation that might, throw their lives off course. And so it was from that perspective that I started to be curious about the story.
And you were curious enough to go back to Latin America, to South America, I guess one would say, and actually establish yourself there.
Right, that's right. So in 2017, I began making trips from Florida, but it quickly became clear to me that I had to move. So yeah, by 2018, I was set up there to spend more time with the research group working with this family, and to get to know the families themselves.
That is a degree of commitment to a story, to embedding with a story that is really remarkable.
Yeah,
was
both
it hard? Was it hard emotionally, and was it hard journalistically to find your way into access to these people?
Well, so that's the interesting point. I mean, that was an interesting aspect of it. So as I just said, like, this story has been told many times. It was one of the first times as a journalist that I'd gone into a story that there were a lot of ink had already been spilled on. So I wasn't quite sure at the time what I was going to be what I was going to be able to add to that. What was interesting is that by the time by 2016, when 60 Minutes it was talking about the Alzheimer's, excuse me, like by 2016, when 60 Minutes had come in and was talking about the Alzheimer's families, there had been a narrative that was already established about Dr. Lopera and how he discovered them and how they related to him. And that narrative was very much sculpted by the researchers themselves, the research group. So I believe it, I kind of came to think it was sort of spoon-fed to journalists who visited for a week or two over time. I didn't really get that spoon-feeding treatment because I had moved there, so there was no urgency in taking me around. That allowed me to make my own relationships with the research team and also with the families. I was never introduced to a single member of the families. I actually hung around the clinical trial area, or would come to events when they all got together, and make my own relationships with them. So none of it was mediated by the research group. And that ended up being very important because, as we can talk about later, I wasn't sure that the family's interests and the researchers' interests were always one and the same.
We should probably just like move back a bit in time and talk about the portion of the story before you entered the story. It's so sad that the person who's the scientist who's so important in this book has just died, but tell us about him and tell us about how he came to this extraordinary discovery.
So Francisco Lopera was a Colombian neurologist who had come from a farming family. He didn't come from an educated family. His father had never set foot in a school. And so he grew up actually in the same rural area that many of his first patients came from. When he met his first patient with early onset Alzheimer's disease, it was 1984. And Dr. Lopera was doing his residency in neurology in a public hospital in Medellin. And a man came into the neurology department who was 49 years old, but with advanced dementia. So, there were cases of early onset Alzheimer's in the literature. It was a known thing, and it was maybe suspected that he had it. But what was interesting about Dr. Lopera is he wasn't really content to just diagnose it. He actually traveled out to the remote hamlet where this man came from, which is kind of an extraordinary effort, considering that at that time it took hours to get there, and you had to take a horse, and you had to take maybe a mule after you got off your horse. I mean, there were a lot of obstacles to getting to these highland farms. When he got there, he discovered that not only was the man sick, his brother was sick. And not only was his brother sick, but his mother had died of something very similar. People didn't know what to call it. They called it all different things, but it was a phenomenon where, people behaved differently. They behaved in they would call them crazy, or they would call them, and then proceeded to, have what we know of as the symptoms of Alzheimer's disease and die within a few years of that. At that time, many people ended up in Medellin's mental institution and died there with dementia. So what Dr. Lopera did that was so special was really sit with the families, put together these genealogies, and collect these histories so that some concept of a history of this disease could be established. And that was what he did. But it was not smooth sailing at all.
I am, what you said about how hard it was to reach the families and where they lived. I think it contains within it, and maybe we can get you to unpack this a bit more, a description of what the families' lives were like. We're talking about very poor rural people, I think, right? In quite remote areas. As you said, you might have to take a mule. You might not be able to get even a Jeep up a track. And so what that suggests as well is that where they were, there was very little day-to-day medical care, and families would be taking care of these people who were in advanced dementia entirely on their own, right?
Yes and no. It wasn't uncommon for people to bring their family member from the farms to the state mental hospital in Medellin, which actually became a big source of data about these families. I mean, what Dr. Lopera didn't quite understand at the time was the dimension of this family, how large it was. All over the world, there were, since the 1960s, discovered families with early onset Alzheimer's disease, but the most members of any of these families that had ever been recorded was like 200 people. This family would turn out to have 6,000 people.
Oh my word.
Making them, on an order of magnitude larger than any other family in the world. But Lopera in 1984 didn't know any of this. What he did sense pretty early on was that this was a genetic condition. It was affecting rural people, and it was actually affecting white rural people, which is a detail that became somewhat important later when they were looking for the genetic origins of the disease.
So that implies that when you say they were white rural people, they were not descended from indigenous inhabitants, but rather from long ago colonization.
Almost certainly they were, in some part descended from indigenous inhabitants and Black inhabitants too, because of course, the transatlantic slave trade was present in Colombia in a big way. But basically they looked to be white people, and they regarded themselves as mostly descendants of Spanish colonists. So that became of great interest when, the genetic origins of this disease were sought, and they wanted to understand better how long it had been there. How long was it in these hills without anybody noticing? I mean, these are really bucolic and beautiful areas, just these sort of green hillsides with, a Spanish tiled roof farm where you might have, at that time, 15 kids in a single family, all of them working on the farm. And in some ways, the area hasn't changed all that much. So when the first investigators went out to these places, what struck them is that people were living a very traditional lifestyle. And the suspicion was that this disease may have been with them for hundreds of years. And that actually turned out to be true.
That's an extraordinarily large family size.
6,000?
No, well, that too, but what I meant was 15 children.
Yeah, it was the norm in Colombia, especially in the 19th century, and it actually had a lot to do with how this disease, which, as I just said, exists in Europe and the United States. I mean, different families with different mutations on these Alzheimer's causing genes, or rather Alzheimer's causing mutations on this specific gene, they exist all over the world, but they never really grew to this size. But in Colombia, there was, it was a Catholic and conservative place. And it was a farming society where it was a really good thing to have lots of kids. So that's also how the mutation sort of took hold. And the book gets into, how all this was discovered, who were the original settlers who brought this from town to town.
So these 6,000 people who were related, did they all know at the time that they were cousins or aunts and uncles, or did the study reveal this?
Yes. Yeah. So we're fast forwarding a lot because essentially what happened after Dr. Lopera discovered the family in 1984, Dr. Lopera actually ended up fleeing Colombia for several years because the violence was just out of control. I mean, we're talking about Medellin in the 1980s, Pablo Escobar and his, henchmen absolutely wreaking havoc on society. And during that time, doctors were targeted by right-wing paramilitaries. And so he and many others at his university had to flee, and they left for Europe. So this study might have ended right there, with the one man who had come in, and Dr. Lopera had gone to his village and built out his genealogy. But eventually Dr. Lopera went to Belgium. Eventually he ended up coming back. And it was when he came back in the early 90s that more families started to show up at his clinic. More people started to show up, and some of them had been displaced by the violence, which actually disproportionately affected the countryside in this part of Colombia and started coming into the city. And that's when this case sort of broke open, and they really had started to get an idea of how many branches of this clan they were and the magnitude of the problem.
So explain to us how this actually, how the occurrence of this visible dementia in relatively young people, how did that actually get traced to a particular genetic alteration?
This was very interesting. So in 1989, I was just saying, like, what you were asking me, like, why did you take this on? Why did you uproot your life? Why did you do this? You come to points in your life where, you just need to do something, right? 1989, a doctor showed up in the middle of basically war-torn, Medellin, Colombia, which was, practically in civil war at that time. A Harvard doctor showed up, whose name was 𝐸𝐞𝐚𝐥𝐭𝐡 𝐸𝐸ₐ𝐞𝐚𝐥𝐿 was a neurologist as I just said, at Harvard, who had come to Colombia sort of with a friend, just out of sheer interest in the country, a place where nobody was going at the time.
Hmm.
And so 𝐸𝐸ₐ𝐞𝐚𝐥𝐿 showed up in Colombia, and he was introduced to Dr. Lopera by colleagues. The reason 𝐸𝐸ₐ𝐞𝐚𝐥𝐿 came to Colombia was because his personal life was an absolute wreck, and it seemed like a great idea to get out of Boston or whatever. So all these strange, like, little fortuitous things came together to create this amazing research effort that lasted 40 years thereafter. But anyway, when the neurology community of Colombia realized that Dr. 𝐸𝐸ₐ𝐞𝐚𝐥𝐿, big deal from Harvard neurologist, happened to be live and in person in Colombia, they made a huge effort to get him to see Dr. Lopera, who had this community that he was studying. And it was Dr. 𝐸𝐸ₐ𝐞𝐚𥥗 who convinced Lopera, well, not that he needed much convincing, but that they should mount an effort to find the causative gene.
Mm-hmm.
At the time, we're talking 89, 90, 91, it was not really known which genes caused Alzheimer's disease, especially these early onset familial types. And there had been one gene discovered, but it was known that there had to be others. So the question was there a gene to be found in Colombia? And, if so, was this the gene, right, that everybody was seeking? When you have a family this big, it's a lot easier to prove this kind of thing, right, than when you have a family with 100 members or whatever. They still didn't know it had 6,000 members, but they had the idea that there were lots of people. So that's where the real searches began. Teams began going out into the countryside. Dr. 𝐸𝐸ₐ𝐞𝐚𥗡 was working with a really famous English geneticist named Alison Goat to try and connect these families and try and understand how they related to one another, and try and do what was called a linkage analysis to identify the active gene. And they did. In 1995, they did.
Wow. 11 years after Lopera saw that first patient.
Yep.
For all that time, they could see that this was an early onset dementia, but they did not know that it was a form of Alzheimer's.
Alzheimer's at that time, especially, was basically diagnosed at autopsy, right?
Oh.
You needed a brain to show that you had Alzheimer's disease, because there were telltale amyloid protein plaques and tau tangles, if you know anything about Alzheimer's disease, in the brain. And that was another really important, and it's another story in the book that's like, was a really urgent story, getting the first brain out of these conservative Catholic families who had very specific funeral rites and rituals, and having to convince them, or trying to convince them, that this was, in the interest of science, and then taking that brain and flying with it to Boston to be analyzed at Harvard. But yes, by 1995, they knew that this was Alzheimer's disease.
So go ahead.
Yep. And they had the genetic profile of it. They knew what gene was involved and what genetic mutation was causing it.
I think it would be a good idea to remind the audience exactly what Alzheimer's disease is, because it's a term that is both so common, and I think it's so frightening to people, but they may not understand exactly what that disease constitutes. So a little bit of history.
You could argue, whatever I'll say is not definitive. You could argue that, Alzheimer's disease is still being defined. It is a neurodegenerative disease that can come about in midlife or late life as a result of different genes normally. And then there's, a late life form that's called sporadic Alzheimer's disease in which maybe the gene might not be known. But the key element, or one of the key diagnostic elements, has been a protein called amyloid beta that accumulates in the brain before symptoms start. And this is where those families became really important to science, because if you have people who have a mutation that causes Alzheimer's disease at a certain point in life, like say age 45, you can study those people before they become sick, right? You can do imaging to see how the proteins accumulate in their brains. You can see how the protein affects their cognition even before they have symptoms. So yes, it's a neurodegenerative disease. Its cause is still a matter of controversy. Amyloid beta has been the research focus since the 1980s. And most of the therapies in development or that in 2 cases are actually licensed act on amyloid protein. They clear it from the brain. But again, this is hugely controversial. The therapies don't work particularly well. And there are a lot of other things going on in the body and the brain that can add to or potentially even spark the neurodegenerative process.
I'm going to remind everybody that we are so interested in your questions. So please put your questions and comments in any of the comment boxes or reply boxes on any of the platforms where you're watching us, and I'll start posing them as they fit into the conversation. And I'm going to start with one right now. In what ways, Talia Gordon-Wexler asks, in what ways did family members push back in terms of not wanting to cooperate with the Harvard team, especially in trying to analyze bodies after death?
Well, that's an interesting question. It wasn't that the families necessarily pushed back. It was that there was no concept of brain donation. I mean, even to most of us, that's something of an exotic idea. You know, the idea of giving your loved one autopsy immediately after death, because the brain autopsy has to be immediate. And then harvesting a brain and then turning over a body, to a Catholic, funeral home it was just really an exotic and traumatizing idea to people. And Dr. Lopera did a lot to try and normalize it. And later on that changed. Families were much more enthusiastic. Well, I don't want to say enthusiastic. Nobody's enthusiastic about a brain donation, but they were much, and I don't want to say compliant either. That's a terrible, I'm trying to find the right word, but they did it. They understood that ultimately the research might benefit them or their descendants, and so they were willing to do it. The pushback on the initial donation, though, was bad. I mean, they were threatened because a family of, I think it was 12 children, couldn't agree on whether or not they should donate this brain or not. And at that time, that brain was the only thing standing between them and knowing whether this disease that they were studying was Alzheimer's.
How did that fit in with the narrative that you first perceived when you watched that first 60 Minutes report, that the families were being represented as not interested in their results, not wanting to participate in discovery?
Right. So this is, so when I went into this project, I was 44 years old, which is about the average age of onset for this family with this genetic mutation. I thought that it would be very moving to me, upsetting to me, and sort of existential to be with people my own age who were, experiencing this disease process. What actually ended up happening is that I related better to their kids in their 20s who were taking care of parents in their 40s and 50s with this disease, and who also were thinking about their future in a way that was different from people who were my age at the time. So just so you understand, a lot of these families are effectively, by definition, rural families. This is a disease that occurred in specific villages and proliferated in a rural area. But many of these rural families moved to the city between, let's say, the 1970s and the 1990s, or even the early 2000s, their kids were raised differently with different ideas, and different questions, and different levels of, religious belief. So they thought differently. And that included their attitudes towards science and scientists.
So you felt they were more like you, and they had attitudes that were closer to the way you thought as a North American coming to meet them in their home places.
They asked more questions, put it that way. They asked more questions of the researchers, and they were more demanding of the researchers. When the researchers were first engaged in the countryside in the 80s and 90s, people were generally very helpful to them because these were the only people to have ever paid attention to this plight of these families. Dr. Lopera had a wonderful folksy manner about him. He was from these rural areas. He sort of spoke their language. He was really good on a horse. He could dance. He had all the characteristics of a charming rural doctor. But as the years wore on, as the decades wore on, and study after study after study was conducted in these people, including a clinical trial that didn't work of an anti-Alzheimer's drug, the younger generation really started to ask themselves, what are we doing? Why are we doing this? Why are we lending ourselves to this effort? And materially, the families didn't get anything for it. They gave their brains, their blood, years of their lives in clinical trials where you couldn't even, get pregnant or smoke pot, or, there were all these rules. And they complied with that for science. But, what did they in fact get in return? Very little. And I think the younger generation saw that more clearly.
So we'll get to the clinical trial in a minute, because I really do want to talk about that. But I think that the thread that you're pursuing is really interesting. This question of what does a clinical trial, especially a very long-lasting one, here literally generations, what does it owe to its participants? And does that change if the participants are, say, in the vicinity of Harvard Medical School versus in the vicinity of rural towns in Colombia?
Well, so that question really runs through the heart of this book, which follows the clinical trial. So when I arrived in Colombia in 2018, the clinical trial was already up and running, and it ended in 2022. Participants are not supposed to be paid in clinical trials. That's a thing that's sort of standard ethics. And when I say clinical trials, like if you have a disease that you're treating, or you're trying to treat with an experimental medication. And that's sort of an established sort of rule of clinical trials. But what bugged me throughout this reporting process is that, literally hundreds of millions of dollars, at least $150 million, probably more, came into or through this tiny Colombian research group during the course of this study. And this study was conducted in basically poor people, right? And they really didn't receive any sort of compensation for that. And what, I came to the conclusion that, even if the conventional wisdom is you don't pay people for participating in a clinical trial, there are other ways to compensate them. I was just talking about the young people and their plight. One of the common problems I saw among young people in this cohort of families was that, you're 25 years old needing to care for mom or dad for 8 or 9 years. You're completely derailed from your career, from your studies. What could be done for that person? Could there be scholarships? Could there be preferential employment? So it really doesn't have to be something so like, cash payments. But I really thought that the needs of this population were so huge, that I think more could have been done to address them, and can be in the future.
So a viewer has just asked a question that I think is really important. Neil from LinkedIn is asking, it sounds like there are major ethical issues, or were major ethical issues with this trial. Is it analogous to clinical trials that were done among Black Americans in the United States?
Like Tuskegee or no, well, yeah. Obviously I don't know if I would go that far. These folks there was very careful consent obtained for everybody in the trials, including, with people who might not be functionally literate. They even made, like animated books and stuff. So, and they had lots of meetings to talk to people and to explain, how the drug worked and what the stakes were and what the possibilities were. So in terms of consent, I don't think there was any issue. No, I wouldn't go as far as to say it was unethical in terms of its design. It was designed the way all clinical trials are basically designed, a placebo-controlled trial. The one unusual aspect of this trial that stood out to me and I think was problematic is that, generally speaking, if you're going to do a trial of like you're a healthy person with a genetic mutation, and you're going to try something to see if your disease can be prevented, you are aware that you have that mutation. In this trial, it enrolled people with it and without it who were not told and did not have the option to know. And it was sort of explained away as, well, there's no genetic counseling in Colombia, there's no counselors, there's no way to divulge this information. But as I spent more time with that research group, I realized that this issue went a lot deeper than that. It really had to do with, and I adore Dr. Lopera, and I was honored to spend 7 years working with Dr. Lopera. But I did feel that there was a paternalistic element in how Dr. Lopera interacted with those families. That was part of it. Constantly telling people you don't really want to know whether you have it or not because you might commit suicide. That later ended, that policy ended toward the end of his life, but with difficulty, and that's something I get into.
So let's not lose track of the clinical trial. I said I wanted to go back to that. Right. The team, the institute in Medellin identifies with their collaborators. They identify the gene mutation responsible. So now you have something, you have a potential target, right? You have something that's potentially druggable, and therefore pharma companies become involved. So tell us about that, about how this becomes something that major investment is potentially interested in.
Well, nothing's inevitable, right? I mean, after the 1990s, after they discovered the mutation and they published it and they found all these different families and sort of, described the scope of these families, there wasn't a whole lot to do with them. And the reason was that there was no drug target. I mean, there was an understanding that amyloid beta was, key in the disease somehow. But there were no drug candidates that were of interest until maybe around like 2008, 2009. But even still, there was the idea, even before the drug candidates emerged, that trying something in people before they got sick might be a better bet than trying to give drugs to people after the neurodegenerative process had started. Because, as we all know, with neurodegenerative disease, there's no really, in most cases, no stopping it. So that was the idea, to focus on people who didn't have it yet to see if it could be prevented. And then all of a sudden, this Colombian family that was sort of an exotic, footnote in the history of Alzheimer's research, all of a sudden sort of came front and center. And then the question was, can we really find all these people, these thousands of people who are supposed to exist, whom Dr. Lopera thinks exists? And millions of dollars were poured into the effort to go back into the countryside to all the villages in a very organized way and locate these people. And that was a huge effort. And it was done at a time when the countryside around Medellin was as dangerous as ever. Virtually the entire span of this book, until just recent years, until maybe the last 15 years, Medellin and its environs were really dangerous places to just be, much less be out there doing scientific research, knocking on doors, going to towns where you didn't know anyone. So this was done in an atmosphere of extreme danger. Most people thought it couldn't be done, but it's testament to Dr. Lopera's force of will that it did get done.
That's fascinating. So it was only because of the investment triggered by the findings from the first cohort that actually illuminated even to the people participating exactly how large their family was and how widely distributed this problem was.
They had no idea. Many of these people met their, long lost cousins in the trial itself. I used to hang out all the time in the trial waiting room, and it was really, really interesting. People from different villages with different stories, and, they were connected in ways they didn't even know, but they got to be friends. They got to know each other during the course of this study.
While this was going on, I think, other things were happening, like other trials were going on, other drugs were being investigated. And as you referenced right at the start of our conversation, there has been no slam dunk, right? There was nothing was working.
Yeah.
Did the fact that these other trials were continuing, and research, of course, was continuing elsewhere, did you perceive it affecting how the trial in Colombia was going?
No. Well, yes. I mean, at the very so when this trial got off the ground, it was announced in the New York Times in 2010, with great fanfare. The first dosing started in 2013, and I got there a few years later. I got there in 2017. Really, at that time, there was already concern that something wasn't working. They were simultaneously trying this same drug, which was called crenezumab, which is a monoclonal antibody and delivered by infusion that, is supposed to attack and clear, and it does attack and clear amyloid protein from the brain. And there was just concern in other trials of it in other types of Alzheimer's patients, people with late onset disease or very early disease, that it just wasn't working. And so the dose was up like 4 times during the course of this 8-year Colombian trial. And the other thing that happened when I got there, it wasn't supposed to be a 7-year book. This was supposed to be like a 3-year book, right? But when I got there, they had to extend the length of the trial itself through 2022. It was supposed to end in 2019 or 2020. So, and that was all to see if they could increase the dose and detect an effect. So there was already like hints of trouble when I arrived.
And we're not spoiling anything for people here because you referenced it at the start of our conversation. This was in the end a trial with a negative result. This drug did not work as
virtually all Alzheimer's trials have been. Yes. And there's no surprise there, really. The surprise would have been had it worked. This was almost the ideal population in which to test this approach. And it still didn't work.
How would you characterize the reaction in Colombia among the families and in the research institute when that that result was announced?
Well, I was there when it was announced, and I was there, and I was there when it was announced to them, which actually occurred after it was announced to the scientific press, quite a while actually after. Everybody got the rumor, though. Everybody knew. So that we're really talking about like weeks apart. I think no one was particularly surprised.
I see.
They were sad, but Colombians are tough people. I mean, they've been through a lot, and they're sort of realists. Many of them enrolled in the trial with the complete, eyes open understanding that it wasn't necessarily likely to help themselves, their generation, but they were participating more broadly in order to help their kids or their grandkids. So I think there was a certain level of acceptance. And then at the actual event, I think what happened was the research group wanted to tell them formally. They wanted Dr. Lopera to deliver the news. And he did beautifully. And, then they spent the rest of the afternoon eating, drinking, dancing there in the courtyard of the university trial center. So, again, I had spent years as a health reporter. I had never spent time inside a clinical trial. And I'd never even heard of this idea that a clinical trial investigator would be spending time with his subjects in that way, because it doesn't happen. It doesn't happen. This was not just a regular clinical trial. This was recruiting a whole family.
Knitting back together a family in order to recruit them. That's one of the aspects of the story that I find so stunning.
Yeah.
So while this was going on, I think we should probably talk about the drug Aduhelm. There's a very high-profile Alzheimer's drug approved and then effectively, I think, disapproved in the United States. So
No, the manufacturer just decided not to market it. Yeah.
I see. And there was a question, I think, of whether Medicare or Medicare was going to pay for it. An enormous amount of media attention to it, but it's the same story, right? It's an amyloid focused drug that turned out not to work.
These drugs are all in the same class. So the same class of drug that was tried in the Colombian families was also tried in different contexts, different drugs. Aduhelm, as it was later branded, it was called aducanumab. It was a monoclonal antibody developed by Biogen, tested in people with late onset Alzheimer's disease, not early onset disease. But the real scandal there, to me, was we didn't know in Colombia if the families were ever going to get access to crenezumab, assuming that it did work. I mean, that's a lot to assume, but in the event that it did work, and that was something I asked of everybody. I could never get a straight answer from anybody about, including the drug company itself. What happens if this works in these people? In Colombia and a lot of Latin America, drugs can be really hard to access. Even like common generic drugs, like there are periodic shortages in Colombia, Mexico, and stuff. Sometimes you have to sue to get your, $100 a month drug. So the cost of aducanumab when it came out was something like $50,000 a year for a drug that slowed Alzheimer's disease by something like 22% over an 18 months. I don't remember exactly what the time period is, but it amounted to only a couple, really 4 or 5 months of actual benefit for the patient. And I calculated that a Colombian making minimum wage, which half of Colombians make Colombian minimum wage, it would have taken 18 years of saving to purchase 1 year of treatment at that price. Now, normally these drugs don't go on the market at $50,000 in these countries. They set them differently. But a drug that goes for $50,000 in the United States might well go for $5,000 or $8,000 in a place like Colombia, and even that is like absolutely inconceivable. So my sense was that from day one, this was never going to be a drug that they could access, even if it did work.
So that slots, we have a question that slots nicely into that from Victoria. She's asking, how did the investigators keep patients and families engaged with the trial? And what I want to ask, sort of to piggyback on that, is when they discovered when the results were announced to them, even though, as you say, they had this amazing party, did they feel like they'd made a difference? Did you have a sense from the families that they felt that they had made a contribution?
Well, I'll answer the second part of that first, which is that, like, at the beginning of all this, there was a concept, it was reported, that the Colombians knew that the eyes of the world were on them, and that this was being done for global Alzheimer's disease, et cetera, et cetera. My experience with people, and this is just sort of normal and natural, is that they were doing it for their personal reasons, to do something active about this disease, for their families, and for the hope of the next generation. Back me back into that previous question too.
So how did the families, how were they kept engaged?
Okay, right.
As the trial was extended, or as it started to seem, as you said, they sort of had an organic sense that things weren't necessarily working.
Well, so that's a really good question, because, by 2018, when I got there were already visibly sick people coming in for their infusions, or at the time they were shots. They converted them to higher dose infusions in the middle of this. So that was demoralizing. And Dr. Lopera was very good at, he would have these like annual Christmas parties and address people's questions. And people were saying, what's happening? He was always frank with them. He never misled them. He was always frank with them, saying that this is a placebo-controlled clinical trial. This is an experiment. This may or may not work. He was always very upfront about that fact. I don't think he sold them on any bill of goods. How were they engaged? That's a really interesting question, because when the trial wrapped up, there's a lot of bragging about the retention rate of this trial, which was almost like incredibly high, like 96% of people stayed in the trial, and the couple people who dropped out because of pregnancy or they moved out of the country. There were just things that you couldn't do anything about. So people stayed in the trial. I said that people were not compensated. I wouldn't go, they were compensated in the sense that they were reimbursed for like a day's lost wages, or, if you had an MRI or a spinal tap, which was part of the trial protocol, you did get money. Those sums felt trivial to me, knowing what kind of sums were flowing through this research effort, but they were not trivial to them. So, talking about the retention rate as like this, noble, like commitment kind of thing, that may have been an aspect of it too. But I also think, it was enough. And Dr. Lopera he knew his population really well. And he always kind of knew exactly how much he should set those prices at to make them meaningful to people.
I'm going to ask you one final question about the story in this book. But first, so many people in the comments have asked questions about your reporting process and your writing process that I want to be sure, especially since some of them are writing students, that I get to elevate those. So I have a question from Michelle. What choices in storytelling did you find were most effective for capturing this human cost? And then right at the top of our hour, Alexa asked, how did you decide on the narrative structure of this book, particularly interweaving the medical mystery and the personal stories?
Okay. So the question was, the reporting process. I was involved with I pretty much went to everything I could. On the clinical side, I forced myself into everything from autopsies to patient consults, again, with the permission of the patient. The privacy laws are not, this book never could have been reported in the United States because of HIPAA and because of different privacy considerations. In Colombia, I only really had to ask the patient and the investigator if I could sit in. It's so common to have also medical students and all kinds of students around. So in the clinical setting, I just kind of stuck myself into any space, laboratory, consult, whatever. I met families that way. I followed many, many families. Not all of those families got into the story. And it was heartbreaking to sort of cut them out. It was awful, having spent all this time with them and having been in their homes so much and having followed their stories. One thing that I think is really, really special about this book, which is very different from any other reporting that's been done on these people, is that, you have what's called in science like a cross-sectional study versus a longitudinal study. Cross-sectional study is a slice in time. You show up, you ask people about the disease, you see what's going on, you report it. What I was able to do is I had like a longitudinal, well, at least a chunk of time, 6-7 years of straight reporting. I could see how people were living with the disease. I could see how people's attitudes toward the research changed over time. I could see younger people, say, becoming more cynical, or I could see people becoming disappointed who were, kind of enthused at the beginning, and I could see the changes that were occurring in their own lives as a result of being research subjects and living with the specter of this disease. In terms of really choosing and weaving things into the narrative, that longitudinal thing helped because scientific things were occurring at the same time that these personal things were occurring. So I have one scene where I'm with a young woman who is Daniela, who's like my main protagonist, who's like 25 when I meet her. And she's going to try and get a genetic test on her own. The researchers aren't going to give it to her. So she's trying to go out and get it on her own. And then we come back to my apartment and I get a text from Dr. 𝐸𝐿𝐴, Lopera's collaborator in the US, saying, bad fucking news, and the text referred to the big trial failing of crenezumab in its other, its other trials that were going on. It was a really bad omen. So I was able to see all this simultaneously. So therefore I could pull the scientific elements that were happening at the same time and sort of intersperse them and braid them into the human narrative. But actually choosing that was really hard. I had very good editorial help on this book. I had 2 editors. I had a first editor who was sort of like a visionary, and he was the one who bought the book, contracted this book. He didn't want to contract it for 7 years. That just sort of happened. I just blew deadline after deadline. But the second editor, after he left Random House, the second editor was a lot more bare bones and a lot more, she was all business. And she helped me mercilessly cut, and until we had a story that flowed, I think, very nicely.
Thank you for answering those structural questions. I am obsessed with structure, and I'm just daunted by the imagining the amount of material you must have had to organize and how much you must have had to discard. I've been in that situation of having reported on people in a cohort and having to discard some people's stories because there's simply not space, and it's heartbreaking. And it's awful to have to tell them that you're not going to make their suffering public when they have shared so much with you.
And they really wanted that suffering to be public. And that's something that I found throughout this, that they really wanted their story to be told. And I was honored to be able to do it.
So I always like to ask people as we're closing up these conversations, was there a takeaway for you? Is there any one thing that you learned or that you want people to take away from the experience of hearing you talk about the book and hopefully going and buying the book and reading it themselves? What one lesson that stands out?
It's not a lesson. It's surreptitious what I did. This is a book about poverty, right? It's not, it's about doing research with no money, right? Because you're in a poor country and you're at a public institution in a Latin American country where, there might be strikes at your university, paramilitaries might attack your university, guerrillas might attack your university or be within the university. And it's a story about living with a disease that is inherently tragic, but in my estimation becomes doubly so when life itself is really hard. And so I looked at, this book is full of the lives of all of these, a number of people, young people and middle-aged people, and generational stories, because there's plenty of generational trauma. That's a cliche to say it, but there's plenty of generational trauma in different aspects of their lives. The disease itself causes trauma, and their lives were, full of escapes from the countryside, escapes from guerrillas taking your farm, sexual assault and rape and incest. This is all part of rural hardscrabble life, and it became a part of urban life for these families too. So I don't shy from any of that. And I think that what I was always trying to do is I treated the concept of poverty, right? Like contraband. I wanted to smuggle it into absolutely everything. Poverty is the backdrop of this story.
Thank you for saying that. Thank you for reminding us what these people lived within and what the researchers struggled with. It's gorgeously knit together. It's an incredibly important and moving book. Thank you for talking to me about it.
Oh, I enjoyed it so much. Thank you for the chance.
So that's it for this edition of the Health Storytelling Author Q&A series. Please consider following Jennie on social media. She has accounts on LinkedIn, on Blue Sky, and on Instagram. And buy the book. It's available at her publisher Riverhead, which is an arm of Penguin Random House. It's at Amazon, of course. But we like to recommend bookshop.org, which is kind of the anti-Amazon. It funnels orders to independent bookstores. And then please join us next month. On October 22nd, Star Vartan will be here talking to me about the stronger sex, what science tells us about the power of the female body. And visit our RSVP page to sign up in advance for that live stream and our later one with Aram Alam, PhD, about immigrant physicians. Until next time, I'm Maryn McKenna on behalf of the Center for the Study of Human Health at Emory University, the Georgia Center for the Book, Emory's Center for Public Scholarship and Engagement, Ideas Festival Emory, and from me, thank you for watching. See you next month.